Everyone. It's so nice to see so many familiar faces. I wish it could be in person, but hopefully that will come at the Advancement Center sometime this year. It's my pleasure to introduce Dr. Angelique Cohen to all of you. She's our new Executive Medical Director, and she came to us from Nashville, where she was with Ascension Health, where she was the Director of Clinical Transformation, and that included value-based care. She went to Rush Medical School, where she was a valedictorian, and then she had an ENT practice that she ran for about 8 years. During the time, she did an MBA and loved a lot of parts of MBA. And when the opportunity to get involved in quality and clinical transformation came, she took it by the horns and did a wonderful job at Ascension. And we're delighted she's here with us. She's spending most of her time with AHP and part of her time with Mike Apostolakis at the Quality Institute at Strong. So, Angelique, welcome, and take it away.
Well, thank you so much, Bob, for such a nice introduction. I really appreciate that. And it is so nice to meet all of you and see the screens of so many faces. Many of you, I'm looking so forward to meeting you. So I really just want to say thank you for allowing me to join you, to be part of this really big team. And I'm really excited to be here. So Jana, could you start the slides? All right, we'll go to the next slide. So just a big hello. Tonight is a very exciting night. It is our clinical grand rounds, and I'm going to start out with the agenda. If you could go to the next slide, please. So, admittedly so, I'm going to be sharing with you quality performance for 2023, what's in store for 2024, and what AHP is exploring in 2024. And this is always a little bit weird, right? Because I haven't been here throughout 2023, and all of you have worked so very hard to get these great metrics going, all the hard work you've put behind all of this, and I'm new and telling you how you did. So I just want to acknowledge that that does feel a little bit awkward, and I am very impressed with all the work you do, and I'm really excited to learn more and to help support you however I can. So I just wanted to throw that out there just to begin. So you guys could probably tell me more about these metrics than I can, but we're going to get started. All right, so next slide, please. All right, so we're going to start out looking, my understanding is that this is not your typical view as a provider when you're looking at your own metrics. And so I just want to acknowledge that and share with you exactly what we're looking at. I know you've seen this before. I know Chad did such a great job in presenting this data for you last year. So it looks very similar. The adults are on top, the pediatric patients are below. However, I want to point out that this is Excellus commercial. So this does not include the Medicaid patients, the Medicare patients. So we're getting a very different view of our population when we look at that. And I just want to make you realize that this looks great. There's a lot of blue on this, and we're going to go over some of this. There's still work to be done with some of our more vulnerable patients. And the reason that we're sharing this particular data with you is because it's a little bit cleaner. And as soon as we're able to get all the numbers from the other payers, certainly that will be shared with you as well. In addition, when you look at these numbers and you're like, ooh, I don't like the pink and the red and the yellow, just remember that we're only 3 quarters in. You've got like a whole nother quarter to meet these goals and close these gaps. So just wanted to share that with you so that you understood that. So we're going to start with, I'm going to move this over here. So I'm going to start with just the breast cancer screening, colorectal, amazing at the 90th percentile. Diabetes has a little bit of work to do. I know that there's been some challenges in terms of the eye exam, both within the office and maybe with referrals. So certainly that is understandable. And it looks like there's a little bit of room for hypertension, blood control of our patients. Those gaps are not gigantic, and certainly there's another entire quarter to get that done. So if there is something we can do to help you to close those gaps, please reach out to me, patient lists, or whatever we can do to support you would be absolutely within our measure. The pediatric numbers look really good, right? They're already all in blue, and they've done such great work on their immunizations. A really big shout out just to the HPV. That is certainly not an easy measure and certainly not easy in this day and age. The well child visits also doing very well. What's not measured on here is our behavioral health, and I just want to recognize the behavioral health team for all that they've done. We know that behavioral health is a strong driver of the outcomes of all of these measures, and so that team just continues to do really amazing work, and I look forward, as we all do, to working with them in 2024. All right, any questions about these measures? All right, next slide, please. All right, so what's in store for 2024? First is, I think you all know, we all heard you that there are problems with the data and getting clean data, getting it fast, getting it relevant has been a little bit of a challenge, as I've been told and understand. So we are moving to a new platform. That platform will hopefully be up and running at the second half of 2024. Of course, no dates can be absolutely promised, but that work will begin in early of 2024. It's just going to take a little bit of while to make it fully functional. In the meantime, we will be transitioning to from Arcadia. Obviously, you all know that these metrics are so important as they drive our focus and allow us to focus on what we need to do to improve these metrics, but really to help our patients and to help you help your patients. Provider engagement. This is nothing new, but we just wanted to share that certainly we are very committed to adding and providing continued support to all of you. We want to find out how we can best add value to you as AHP. But in order for us to do that, we need your feedback of what you need from us, very open, transparent feedback. You will be getting a questionnaire soon. I don't know exactly when, that will be asking you some questions around this, and that could continue to happen intermittently throughout next year. There's also a lot of work being done on the website, so there will be a new, enhanced, and updated website that hopefully feels light to use and very intuitive as you're in there, and hopefully that'll actually make you want to jump in there more often and check out some of those provider tools, guidelines, or whatever you might need. In addition, advocacy, as you know, is a big part of AHP, so we continue to be in active discussions with payers to establish reasonable and achievable quality goals and making sure that those thresholds are reasonable. We do not have those thresholds to share with you tonight. As soon as we get those, we will go ahead and make sure that you are aware of what's coming up for next year. Any questions about 2024? Okay, I'm going to move on to the next slide. Great. So what are we exploring for 2024? And I'm using that word exploring because that's exactly where we are right now. And the first thing we're looking at is high-cost geriatric home care, home visit program, rather. These patients, as you know, often can exceed the capacity and capability of our providers, not because they're not able to, but you don't all have the resources. These patients really can take a lot of resources and a lot of help, and we want to help you and help your practices assist in the care of some of these patients. This would be an APP really driven proposal with a geriatrician overseeing that work. We'd be looking at the possibility of making sure that MedRex, medications, polypharmacy, all of that is evaluated. Also considering in-home medications such as IV Lasix, nebulizers, and really thinking about goals of care, advanced directives, and palliative care hospice services. Next is pediatric complex care. So it's sort of the same, only the opposite end of the lifespan. So this is really looking at our children, particularly those complex pediatric patients, maybe those patients that are really at risk for fragmented care and are in regions within New York that are hard to access. They don't have the same access that the rest of our patients may have. So this project is really to provide care coordination, case management, behavioral health consultation for these patients to try to keep them out of the hospital and improve their quality of life, decrease their ED visits, their readmissions, duplicative treatments. So they see multiple specialists. People could be ordering and testing similar tests and medications, and also to close gaps. As we look at any of our initiatives going forward, we really are devoted to using a behavioral health lens, as well as a diversity, equity, and inclusion lens. We know that without both of these, we can't really support this very large community that we need to support. All those are very, very important. And if we overlook those, we won't be able to really provide the value that we want to provide both to our providers nor to our patients. We're also looking to hopefully expand the 5 Contacts readmission program. More to come on that. We also want to evaluate the metrics related to that, the steps and how each step is contributing to the readmissions reduction. Next is brain health. Some of you may not know about brain health. This is a project from our neurology partners. They are looking at neurologic disorders. As we know, this is one of the leading causes of disability throughout the world, and many of these diseases are preventable. So this is really working off of a pilot from before, where they're going to do a retrospective analysis, facilitate Brain Health Community Advisory Council, and really do a lot of education to a specific group of patients, all about prevention. Any questions about the explorations for 2024? All right, next slide. So this is a virtual meeting. I understand that. Please feel free to reach out to me, call me, email me anytime. It's totally fine. I hope to be meeting most of you in person, if not all of you. And so please just reach out for anything that I can do to support you or to do something different if I'm not doing something you would like me to. All right, any questions? All right. So I think that I am going to go ahead and hand this off to George and Holly. George and Holly, I'll let you guys take it from there. Jana, I think you're doing the screen sharing.
George has elected to run his own slides tonight,
Oh,
so he will jump in there to do that.
How about
Thank
that?
you. Thank you, Angelique. Thank you, Jana. Let me share my screen.
And while we're waiting, I'll just say George and I are really excited to talk with you guys tonight about ADHD. And we thought we'd have a little bit of back and forth between the two of us to keep it interesting. Right, George?
Absolutely. Thank you. And I really appreciate your collaboration on this, Holly. And before we start, I want to recognize LJ for all the support for behavioral health over the years, and recognize also Angelique for all her support so far. So thank you both. We are presenting today in a relatively short time. We wanted to talk to you about ADHD across the lifespan. This is not going to be a comprehensive presentation. However, we are also asking that you reach out to us, both myself and Holly, if you have specific questions, specific patients, cases, situations you want to discuss. We'd be more than happy to work with you and kind of brainstorm solutions to any questions or problems that you may have. So one question that comes up is diagnostic criteria. How do we approach diagnosing ADHD? So really, this is a complicated, complex diagnosis to make, both for primary care and also for psychiatric providers, to be honest with you, because of how this diagnosis spans multiple domains, multiple areas of functioning, comorbidities that are involved in ruling out before a diagnosis is made. So there's a lot that goes on in making the diagnosis itself, and then the treatment carries some risk, right? So the treatment of ADHD with stimulant medications, sometimes misused, sometimes diverted. So there's a lot of hesitancy in making the diagnosis and hesitancy in actually treating this disorder. But basically, there are these two domains of functioning, right? Inattentiveness, inattention, and then impulsivity, hyperactivity. Those are the two domains that fall into the diagnosis of ADHD. So we say attention deficit hyperactivity when most of the symptoms cluster around impulsivity, hyperactivity. We say attention deficit disorder inattentive type when most of the symptoms cluster around inattention. And those are the 9 criteria in each of those domains that follow the DSM diagnosis. We need 6 of those in combination or in one or the other of those domains. We need 6 of those to make a diagnosis of ADHD in children. We need only 5 to make a diagnosis of ADHD in adults. Did you want to add anything to this, Holly? So far, it's the same for adults and children.
Right. So the thing that I just wanted to point out is this notion around criteria C, the 2 setting rule, right? The idea that these symptoms show up across multiple domains. When we think about kids and adolescents, of course, we're thinking about what's happening at home and what's happening at school. But for adults, you know, the notion of what is their work experience, right? And, you know, are they sort of in and out of jobs, not achieving the way that they had hoped in terms of their employment? So that 2 setting rule is an important piece. But George, I want to ask you a question, right?
Yes.
Is the diagnostic criteria and sort of, is there more you want to know in terms of hearing from the patient about their functioning, particularly with adults?
Yes, of course. So these are the symptoms, right? So in any psychiatric diagnosis, symptoms alone do not constitute a diagnosis. What we need is the symptoms that cause significant impairment in functioning. And you mentioned some of that, Holly. So those symptoms, whether it's excessive talking or difficulty with sitting still or losing objects, are not really a diagnosable problem unless they impair someone's functioning. And you said that they should impair someone's functioning in 2 different settings, and that's also true in adults. At the same time, we want those symptoms to be sustained over a period of time. So there's no such thing, especially in the adult population, there's no such thing as adult onset ADHD. The person who comes to my office, for example, and says, I've been having ADHD symptoms for the last year with no prior evidence of symptoms, that is unlikely to be an ADHD diagnosis. So the symptoms have to be sustained, and we insist on having some symptoms, some impairment, maybe not meeting all the criteria, but some symptoms have to be present prior to age 12. And that's true for the adults, and that's also true for children. Now, you mentioned the two setting rules, and I said that they should interfere with functioning. And also criteria E tells us that we should rule out comorbid conditions. So if someone has symptoms of ADHD only in the context of anxiety, and their anxiety symptoms are fidgetiness, irritability, forgetfulness, then that's unlikely to be ADHD. That's anxiety and should be treated as anxiety before we move to making a diagnosis of ADHD. That's also true for depression, substance use, and let's not forget that things like caffeine intoxication can cause symptoms similar to ADHD. Let's not forget that untreated sleep apnea can cause symptoms similar to ADHD. So the comorbidity is also something that's important to mention. Would you agree, Holly?
I would agree. I think, one of the other questions that I had for you, George. So when I talk with the pediatricians in the AHP network, they always tell me that they send Vanderbilt rating scales out to the parents and to the teachers to get data back to help them understand the symptoms and its impairment. What happens on the adult side with rating scales?
That's a great question. Yeah, rating scales are important and very helpful, especially in children. And in fact, the American Academy of Family Medicine recommends rating scales as part of the diagnosis for ADHD. However, I want to stress that the clinical interview remains the bedrock of ADHD diagnosis. And that's true for adults. And I think also that's true for children. So rating scales are a helpful tool to support the diagnosis, to measure the intensity of the symptoms, maybe to measure improvement over time. But relying on rating scales alone to make a diagnosis of ADHD is not really what we recommend.
Great. So if we go to the next slide, George, just to review.
Yes. So
right.
This slide talks about something that you mentioned, Holly, around impairment in functioning. And I'm talking here about impairment in at work as well as at home. So these symptoms of ADHD are executive functioning symptoms, right? So they're going to cause someone to have poor performance, poor time management, difficulty in organizing tasks at work. And that's the person who's going to have difficulty finding a job and maybe difficulty keeping a job. That's the person who's going to have difficulty keeping up with training on the job. They're going to lose opportunities for promotion. And at home also, these are the kinds of individuals who are having difficulty with interpersonal relationships, irritability, maybe losing relationships, maybe having difficulty maintaining relationships, communication problems. So these are these are symptoms that significantly impair someone's functioning in the real world. What do you say on the child side, Holly?
I would just say one more word about this. I'm paying attention to our time too, but I think our pediatric folks do a great job, identifying ADHD, working around ADHD, appreciating how the symptoms get in folks' trouble. But when we think about our transition age kids, right, our teenagers that are moving into college settings, you start to see things the structure of school, formal school sort of. You see the loss of that sometimes with our college age folks where they have a difficulty time, adjusting to that schedule, managing their time, sometimes having a little bit too much fun, and then really struggling to get down to business as it relates to their academics. So that is something to kind of keep in mind and pay attention to that nuance in terms of how they were functioning prior to going to college. And now that it's really on them, you may see those symptoms be more present.
Yes, thank you. And this slide we talked about, I'm not going to spend too much time, but just to emphasize the importance of comorbidity in ADHD, it's quite high. And because it's quite high, it's also important to treat the comorbid condition first before addressing the ADHD. Now, sometimes we need to address both at the same time, but most of the time it's a situation where if depression is present, we need to treat that depression. If bipolar is present, we need to address that first before we make a diagnosis of ADHD.
Yeah, and the list for us on the child side looks real similar. I would say probably the other thing that is highly comorbid, which is a different grand rounds, is oppositional defiant disorder, right? So that can often be the ticket of entry to wondering about ADHD.
Yes, thank you. Now, what about the treatment options for ADHD? Again, there is some variability between children and adults, but the concepts remain the same, right? So the first thing I want to emphasize, and I think Holly would agree with me, that non-pharmacological treatments are really important in ADHD. Remember that patients with ADHD 20 to 50% of them are considered non-responders to treatment, to medication treatment. And even when we say response is defined as 50% improvement in symptoms. So what I'm trying to emphasize here is that there is significant residual symptoms even when someone is responding to medication treatments. And if we agree that the ADHD pathology, ADHD is a neuropsychiatric disorders that affect the prefrontal cortex with executive functioning. Now, what are those executive functioning? That's sustaining and shifting attention. That's inhibition and impulse control. That's working memory. That's planning and organizing. Those are the areas of dysfunction that ADHD cause impairment in, right? So non-pharmacological treatment, psychotherapy treatment for ADHD falls into two categories. One, improving those symptoms or finding alternate ways to address the deficits in terms of organization, planning, teaching people skills, right, to address those areas of deficit. And the other area is to address those long-term sequelae of ADHD. So someone with ADHD over a period of time, developing depression, developing low self-esteem, guilt, anxiety, anger, relational problems. So that is addressed also in psychotherapy with ADHD. Anything you want to add here, Holly?
No, I would say the 1999 MTA study that was done, that's really a landmark study around treatment of ADHD in kids and adolescents, held up that CBT plus a stimulant is what had the best outcomes. So that all stands to reason.
That makes sense. And then with pharmacological treatment, I have a couple slides on that as well. But basically, these fall under stimulants, non-stimulants, and then those alternative medications that may or may not be FDA approved for ADHD, but are commonly used as well. Okay, so general prescribing tips, right? So people want to know, so what do I start with? How do I initiate treatment for ADHD? I'm gonna give you some thoughts, and Holly and I kind of will discuss how this is different or the same between children and adults. So stimulants are generally more effective than non-stimulants. We know that, right? So if you want to prescribe Strattera to a patient or Wellbutrin to a patient, studies show that the benefit is less than a stimulant. However, that does not mean that we always go to a stimulant medication as a first choice. There's other factors involved in that decision making. Then we talk about choosing between long-term and long-acting and short-acting medication. Now, here it's more of an art than a science, and I don't know if Holly would agree with me, but there is benefit and risks to each one of those options. So, for example, there is some evidence that longer-term stimulants prevent the psychological dependence of having to take a dose repeatedly throughout the day, and that may be less likely to cause dependence on the medication. There are, however, studies that show that short-acting medications allow the person to sleep better because they act for a shorter period of time, or allow a kid to regain their appetite before the next meal because they're short-acting that way. So it's a case-by-case clinician preference and patient preference situation. Would you agree with that, Holly?
Yeah, I would say that when we have cases of comorbid anxiety or depression, we're going to start there. And so our non-stimulant options may be where we begin first, but stimulants definitely have the data. I do think the practice with kids and adolescents is certainly to move to a long, the American Academy of Child and Adolescent Psychiatry talks about moving to a long-acting stimulant and using short-acting as needed for sure. And to your third bullet, which I'll take that to get us started. Methylphenidate is really the preference with kids and adolescents to start with, followed by amphetamines. But I don't think that's the case with adults, is it, George?
Yeah, so it's complicated. It's a little bit nuanced, I should say, in adults. So the studies show that based on efficacy criteria, amphetamines are slightly better than Ritalin. However, because of the side effect and the risks of misuse, so you're going to see in another slide that amphetamines are 4 times more likely to be diverted and misused than methylphenidate. We also recommend Ritalin or methylphenidate type medications in adults as well as a first choice. Obviously, if someone has a history of substance use disorder or at risk, maybe a family history, then choosing a non-stimulant as a first line treatment is always the best option. And then we talked also about comorbidity and the need to treat that first. I wanted to spend a minute on this slide and say that many patients will need to try different medications until they settle on the one that works for them best. And therefore, just knowing in general how to switch makes sense, right? So switching from one amphetamine to another, I wrote here that with the exception of Vyvanse, all amphetamines are roughly equivalent in terms of dosing. So if we want to switch from Dexedrine to Adderall, it's the similar dosing. Would you agree with that, Holly, or that's not something that you follow?
I do.
Okay. For Vyvanse, it's a whole different story. So Vyvanse lists dexamphetamine really is a, as you know, it's a mixture of lysine and Dexedrine. And the reason for that is Vyvanse is a prodrug, right? So mixing it with lysine makes it ineffective. And it's not until it's broken down in the gut to Dexedrine that it becomes an active medication. But because there's a significant proportion of it that's lysine that's not active, then really what you're giving your patient is the 30% Dexedrine. So switching from an amphetamine to Vyvanse, you want to at least double the dose of the Vyvanse to have the similar effectiveness. Then we have switching from one methylphenidate to another methylphenidate, let's say from Concerta to Ritalin or vice versa. Concerta is the exception. So with Concerta, the conversion percentage is 83% roughly. So if you go from Concerta to Ritalin, 18 milligrams of Concerta would be 15 milligrams of Ritalin. 36 of Concerta is 30 of Ritalin, and you know, you go from there. So there's a little bit of a conversion. Why is that important? Because people come to us on one medication, need to switch to another, and if we don't follow the equivalency in terms of dosage, they're not going to do well on this medication. Then from methylphenidate to amphetamine, it's basically half the dose as a general rule. So going from Ritalin to Dexedrine, Ritalin, which is a methylphenidate, 10 milligram would be equivalent to 5 milligrams of Dexedrine, which is an amphetamine. You want to add anything to this?
No,
Holly?
this is great. We should talk a little bit about misuse, though.
Okay, so misuse is really a complex story. So one thing to remember is that yes, and stimulants can be misused, and stimulants are chemically the same chemical as cocaine, right? It's a stimulant medication. It has a high, it has a street value, and it can be misused. At the same time, ADHD is a risk factor for substance use disorder. People with ADHD are at a higher risk of using substances, including cocaine, including nicotine, and other substances like alcohol. So it's not a simple equation of I'm never going to use stimulants, because if I don't treat my patients with ADHD, I'm also keeping them keeping that risk of substance use basically untreated. So there is evidence in the literature that effective treatment of ADHD can reduce the risk of substance use over time. So it's really a complex story to be taken into consideration here. And we talked about amphetamine being misused 4 times more than methylphenidate, and that's why both in adults and children, actually, we recommend methylphenidate first before amphetamines. And then the last bullet I wanted to emphasize that 20 to 50% of adults, I don't know about the data for children here, maybe Holly would know, but 20 to 50% are the ones who exaggerate symptoms with the goal of obtaining a stimulant. So that's a significant proportion. However, it's not the majority of patients, right? So that's also something I want to emphasize, that most patients are not going to exaggerate their symptoms, but some will.
Yeah. And so the only add to this is the notion of who are the adults in the home, and how are they, what are they thinking, and sort of how are they responding to the idea of a stimulant for their child. Is there an eagerness, is there a concern about adult substance use in the home that may be problematic? So that is the bigger thing. And then of course our adolescents and college age students, we want to be on the lookout for these things that George has already talked about.
These red flags, basically red flags for misuse and diversion. We all know, it's common sense. If someone is over endorsing or exaggerating their symptoms, those patients who endorse, all 18 symptoms of ADHD, those patients who are requesting specific brand name medications, specific doses of medications, and insist on nothing else. I'm allergic to everything except for this one. People who refuse to cooperate and collaborate in terms of the workup for the diagnosis. Those are the patients where we say, okay, wait a minute, maybe I should take my time, obtain more collateral, obtain old records, and take my time in making the diagnosis before prescribing a controlled substance for them. At the same time, we all should be mindful of the fact that we carry an implicit bias, and that this bias often causes us to treat some individuals differently, and that's just a fact. Because of that, the best way, if in your practice you want to implement, you want to diagnose ADHD, prescribe medication, then we would strongly encourage you to implement a policy, to develop a policy, apply it universally, use a controlled substance agreement, so that you, your staff, your patients, everyone is aware of how do you approach the diagnosis, when do you prescribe a stimulant, when do you stop prescribing the stimulant, do Do you insist on a drug screen? Do you not insist on a drug screen? So all these things should be part of how everyone is treated in a certain practice.
So how would you recommend, George, that primary care providers think about this comorbidity question? And you had this handy graph here on the next slide.
Yeah, so this is about what do we do when we have a patient, a real patient in front of us, and what if that patient has ADHD and depression, or ADHD and anxiety, or something else? And this is a graphic that's kind of a little bit busy here, but this is from Up to Date, and it addresses that. So I just took the first tier of that to simplify the conversation a little bit, and to say, if we have a patient with ADHD who has depression, then we want to treat the depression. And luckily, we have a medication that's indicated for both major depression and FDA approved for ADHD, and that's Wellbutrin, bupropion. So that would be the go-to medication for a patient with depression and ADHD. That would be how we address that. What if a patient has anxiety plus or minus depression? Then I would say what I would do in my practice is to treat the depression with an SSRI or an SNRI, and then evaluate whether an additional stimulant is needed for that patient. So depression, treat the depression with an antidepressant. Anxiety, treat with an SSRI, and then assess whether there's a need for a stimulant. And if there is no anxiety or depression, and also no history of substance use and or concerns about that, then starting a stimulant is what's needed. This graphic says amphetamine, but like I said, in practice, we always recommend methylphenidate first before we go to amphetamine. I don't know if we have time for questions, but basically, this is the last slide here, and want to remind you that our behavioral health team works closely with your care managers, whether they are embedded or centralized. So that is a resource for you around behavioral health. They can work with us, or you can email us directly. The behavioral health team email is on your screen for consultation, questions, cases to discuss. There's also the outpatient consultation at the medical center at the Department of Psychiatry, and you will get those slides after the presentation on how to refer, both through e-record would be one way, but also if you don't have Epic, there's a way to fax or call to make an appointment for your patient to see a psychiatrist, whether virtually or in person, and have a medication consultation that way.
We believe that in nephrology, and our colleagues that are here with us today are going to really help us guide us in two aspects that are, in the forefront of what we see in our clinics every day. And so we have Dr. Ricky Grewal, who will be talking to us about chronic kidney disease, the workup, when is referral best, what are those best practices, what do we do with CKD 1, 2, 3, 4, 5, when do we refer, when do we not refer? And I think that's something that we all maybe struggle a little bit, and we also may overcrowd nephrology consultation. So it'll be helpful to hear from that perspective, so we can decompress them a little bit, sometimes doing part of the workup ahead of time to give them a break. And then our second speaker will be Dr. Matthew Taylor, also an assistant professor in the Department of Nephrology, talking to us a little about nephrolithiasis, the prevention, evaluation. What can we do in our offices? What can we start before referring necessarily to nephrology? And I think those are two topics that will help, us in the office, and as well maybe help our colleagues, get more time to see cases they need to see on a timely basis as well. So Dr. Grewal, Dr. Taylor, thank you so much for being here, and I'll hand it off to Dr. Grewal to start us off.
Thank you.
Yeah, thank you for having me. I'm going to share my screen here. All right. Everyone can see the screen?
Mhm. Yes.
Okay. All right. Thanks for having me. Like I said, we're going to be talking about chronic kidney disease workup and referral best practices. Just getting right into it, when we talk about the actual definition of chronic kidney disease, according to the KDIGO guidelines, it's defined as abnormalities of kidney structure or function that are present for at least 3 months. The key is it has to be present for at least 3 months with implications for health. We classify CKD based on cause, GFR category, and albuminuria category. And so this table here kind of outlines that, which might be a refresher for many of you in terms of the GFR category. You know, most of us are probably familiar with the G1 to G5, and then there is the little subtlety between stage 3A and stage 3B, whether or not you're below or above the 45 mils per minute on the GFR. A lesser familiar category tends to be the albuminuria, A1 through A3. And so a normal level of albuminuria or mildly increased would be less than 30 milligrams per gram. Moderately increased would be 30 to 300 milligrams per gram. And then severely increased would be over 300 milligrams per gram. And it's important to frame it this way because it helps us in terms of thinking about the prognosis of the patient's kidney disease and potential for progression. And so the patients who fall in the green category are considered low risk. The patients who fall in the yellow boxes would be considered moderate risk, and then orange and red would be considered high or very high risk. And with the caveat that the patients who fall under the green category, so that's GFR 60 or more, but no significant albuminuria, you wouldn't otherwise classify them as having stage 1 or stage 2 kidney disease unless they had some other marker of kidney disease, whether it's a childhood history of kidney disease, they have an atrophic kidney, they have a known polycystic kidney disease. Otherwise, you would just sort of say that they have normal kidney function. Talking a little bit about epidemiology, 15% of US adults are estimated to have CKD1 to CKD4, which represents about 37 million people in the United States. 40% of adults with severe CKD do not know that they have severe CKD. And looking more closely, a majority of the patients with CKD tend to be above the age of 65. But there is a disproportionate number of patients that are non-Hispanic Blacks compared to other ethnicities. And when we look at over the past 2 decades, the prevalence of CKD, you can see it's maybe slightly increased over the past 20 years, not a whole lot, but you can also see that this gray line is the CKD3 patients, and that's a majority of the patients have CKD3. And then to a lesser degree, our CKD4 patients are actually less than 1% of the population. And that's obviously the ones that we're the most concerned about. In terms of end-stage renal disease, certainly the numbers have increased over the past 2 decades. As of now, there's about 808,000 people in the US that are living with end-stage kidney disease. Of those patients, 69% of them are on dialysis, whether that be in-center dialysis and then to a lesser degree, home hemodialysis or peritoneal dialysis. And then about 31% are living with a kidney transplant. And this map is just to show the prevalence of end-stage renal disease across the United States. You can see in upstate New York, Monroe County, we kind of fall into the middle of the pack, so to speak, in terms of the prevalence. I think we're all probably familiar with the fact that chronic kidney disease and end-stage renal disease increase the risk for cardiovascular events and mortality. But just to kind of review here, when we look at patients who have a GFR less than 60 versus a GFR over 60, the patients with a GFR less than 60 have an increased risk for major cardiovascular events, cardiovascular death, and all-cause mortality. And then when we look at patients who are on dialysis, the annual mortality increases significantly for the patients who have end-stage renal disease. And so if you look here for a patient who's a young patient, 25 to 34, who ends up on dialysis, their annual mortality increases 500 to 1,000-fold compared to a healthy patient of that same age. And so that patient's mortality is basically the equivalent of about an 85-year-old patient of the general population. So these patients, certainly when they're young, they end up being very sick and at very high risk for complications. These graphs here are to kind of summarize why we care so much about the albuminuria and also the decline in GFR. And so if you look at, for an example, at a given GFR of 60, for example, these three lines are showing different levels of albuminuria. A1 is in blue, A2 is in green, and A3 is in red. And so for a given GFR, there is an increased risk for all outcomes, including all-cause mortality, cardiovascular mortality, end-stage renal disease, AKI, and progressive CKD. And that persists regardless of what the GFR is. And so that's sort of the thought process behind that initial table that I showed you in the beginning about which patients we're most concerned about. And certainly, as we can surmise, as the GFR declines, the risk for all these outcomes also increases. So brings us to our next question: who should we screen for CKD? I'd say, we're not necessarily suggesting that we screen every patient for kidney disease, but certainly the ones that have risk factors. And so about 1 in 3 adults with diabetes and 1 in 5 adults with high blood pressure may have chronic kidney disease. So certainly those are patients you'd want to screen for kidney disease, but also patients who have cardiovascular disease, obesity, family history of kidney disease, or the use of nephrotoxic medications such as chronic NSAIDs or lithium. And then other less common conditions to think about would be chronic viral infections like hepatitis C or HIV. Sickle cell trait alone is actually a risk factor for developing kidney disease. Tobacco use is a risk factor for developing kidney disease. How do we screen for CKD? I think we're all familiar with the first test, which would be a serum creatinine level to calculate the GFR. And we calculate the GFR predominantly using the 2021 CKD epi creatinine equation, which is non-race based. And that is the equation that our EPIC system uses to calculate the GFR. But there are conditions where we may want a more accurate estimation of GFR, or where we question the accuracy of the serum creatinine. And some of those conditions can include patients with high versus low muscle mass, amputees, patients with neuromuscular disease, and then also patients with varying dietary lifestyles, high animal protein diet, creatine supplements. Historically, we would, in years past, we were doing 24-hour urine creatinine clearances or even glow fill studies to more accurately assess the GFR. But as you probably are familiar, we've started to use a test called the cystatin C level to alternatively estimate the GFR. And to review, the cystatin C is a low molecular weight protein that is filtered at the glomerulus and is not reabsorbed. It is not affected by as many other factors as serum creatinine. It's not meant to be the only indicator for GFR, but it does correlate with creatinine. You can see here on these graphs here that just like how the GFR declines based off of creatinine, as the GFR declines based off of cystatin C, we have an increased risk for death from cardiovascular cause, ESRD, and death from any cause. But there are conditions where cystatin C can also be misleading. Chronic inflammation can lead to an elevated cystatin C. Obesity, diabetes, thyroid dysfunction, tobacco use, and chronic steroid use can all affect cystatin C. And that is why the recommendation is to use the 2021 CKD epi creatinine and cystatin C equation to estimate the GFR, and not just either one in isolation. The other test to help screen for kidney disease is the checking the urine test for albuminuria, and that's typically done using a random untimed sample. Like we had mentioned before, there's moderately increased albuminuria and severely increased albuminuria. We translate the, for example, 450 milligrams per gram. We translate that to be basically about 450 milligrams per day. And then once we have those two pieces of data, we can go back to kind of staging the chronic kidney disease, and brings us back to our table where we have the different levels of kidney disease. And this can help us decide which patients can be hopefully managed in the primary care office, and then which patients we need to refer to nephrology. And so certainly a majority of the yellow and the orange boxes you would hopefully be able to manage in the primary care office, but then the patients who have stage 4 kidney disease or worse, and patients with severe albuminuria, so that's greater than 300 milligrams per gram, those would be the patients that we're typically referring to nephrology. You could argue that for these stage 1 or stage 2s with significantly increased proteinuria or albuminuria, the first option might be an e-consult, which I think many of you are familiar with already. And that can help us let us decide which patients we need to kind of bring in for an in-person evaluation. The numbers for underneath refer to how many times the patient should be evaluated per year or have labs done. And so certainly our more severe patients with severe kidney disease, we typically want to check labs at least every 3 months. And then the other part of that diagnosis or the criteria for CKD is figuring out the cause, which is always sometimes one of the difficulties. This data is based off of the USRDS data in terms of the causes of ESRD. 38% of patients have diabetes as the primary cause, 27% have high blood pressure, 15% have glomerulonephritis, 7% have other causes such as polycystic kidney disease. What other tests should you consider if you weren't necessarily referring patients to nephrology? I think for the majority of my patients, I do a urinalysis to assess for concurrent microscopic hematuria. If there is hematuria, that might make me think that there's more than just sort of run-of-the-mill diabetic nephropathy or hypertensive nephrosclerosis, and might raise my suspicion for an alternative underlying etiology for their glomerular disease. If they just have hematuria and they don't have proteinuria or abnormal renal function, you could argue that you might first refer them to urology for a workup of that, because in the absence of proteinuria and normal renal function, you could argue that even if you referred them to nephrology, we may not do anything in particular, unless they have some history of, some underlying autoimmune disease like lupus, for example, then that would, I think, warrant a referral to nephrology. Kidney imaging, particularly we get that if there's a concern for obstruction, nephrolithiasis, recurrent UTIs, or a family history of polycystic kidney disease. I will say that I tend to get ultrasounds on the majority of the patients that I'm seeing, or at least have evidence of at least moderate kidney disease, particularly if they've never had imaging done in the past. Sometimes you can find an atrophic kidney, you can find cysts on their kidneys. Particularly polycystic kidney disease would be my main concern, even in the absence of a family history. And then oftentimes we will do a spot urine total protein to creatinine ratio in addition to the urine albumin, and that helps us also quantify how much total proteinuria beyond just albuminuria they have. This graph here just shows that the spot protein to creatinine ratio does correlate relatively well with the 24-hour protein excretion. So I don't tend to do a lot of 24-hour urines. I usually start with the spot protein to creatinine ratio because it doesn't usually change my management. If it's 5 grams per day on the spot analysis, it's more than likely going to be relatively similar on the 24-hour urine. And 24-hour urines, as you probably are aware, are cumbersome and difficult for patients. Sometimes they're not even accurate because patients can mess up the timing and measurement. And finally, the question about serologies, that's always a tough one, which serologies to send. I think if there's a concern that it's not related to your typical causes of kidney disease, you might consider sending serologies for specific systemic diseases like myeloma or amyloidosis. Lupus, I'd say, if you're thinking about if they have a known history of lupus, I'd say the majority of those patients we'd want to see in person. Just because of the complexity behind that. And you could argue that, some patients you may even need to consider a renal biopsy because it could change their management. I think we're all familiar with the basic managements for interventions for kidney disease. Diet, hydration, exercise, weight management, and smoking cessation are key. Majority of our patients were recommending ACE inhibitors or ARBs. And then after that, especially in this day and age, SGLT2 inhibitors, not only for diabetic kidney disease, but also for non-diabetic kidney disease with proteinuria. There is data to support the use of SGLT2 inhibitors. If they don't have proteinuria, there really isn't a hard renal indication, but if they certainly have endocrinology or cardiology-related indications, then that would be a potential reason. And then if they're diabetic, you could consider a GLP-1 receptor agonist for there is some data so that they can help slow progression of kidney disease. And then more recently, one of the newer medications is the non-steroidal mineralocorticoid receptor antagonist, which is known as finerenone, or Kerendia is the brand name. That is a much smaller subset of patients that has also been shown to help slow progression of kidney disease, but that comes as sort of third line in my mind after the ACE and SGLT2 inhibitor. There is a mild risk of hyperkalemia with those medications, less so than our typical mineralocorticoid receptor antagonists like spironolactone, but something to consider. This page just sort of highlights the key management interventions. Sometimes I do a lot of the e-consults, and sometimes the questions are, what else should I be doing? I think majority of these things we're already doing in the primary care office, like managing their hypertension and diabetes, and potentially stopping the metformin when the GFR is under 30. I'd say for anemia wise, we typically treat iron deficiency up to allow for a goal transferrin saturation greater than 20%, and tolerate a mild ferritin elevation of about maybe 500 or so. I will tell you that in our dialysis patients, our ferritin levels will treat the iron deficiency up until the ferritin levels above 1200. Just to give you an idea, with the expectation that there is sort of a chronic inflammatory state in the setting of kidney disease. There is data to support the use of sodium bicarbonate supplementation for persistently low bicarb, less than 22, to help slow progression of kidney disease. Treating vitamin D deficiency is helpful because that's potentially a risk factor for secondary hyperparathyroidism. We do tend to expect a level of PTH elevation with chronic kidney disease. The data behind using calcitriol has, I think, in the past couple of decades has fallen out of favor. There isn't a lot of good quality evidence to support its use in the non-dialysis population. There's also the risk for it causing hyperphosphatemia. So I personally don't use it at all really in my non-dialysis patients. And then, of course, hyperkalemia, the two new big drugs that we've had are Veltessa, which is patiromer, and Lokelma. The key to remember with Lokelma is Lokelma does have 400 milligrams of sodium in each 5-gram dose you give. So it's something to keep in mind if you're considering that for a patient who might already have issues with volume overload. We recommend hepatitis B vaccination in our patients who already have evidence of progressive kidney disease, who potentially might end up on dialysis. And then also we try to preserve their veins if we think that they're going to progress to end-stage renal disease and need a fistula. And that's why we typically advise avoiding PICC lines and avoiding blood draws and IVs on the non-dominant arm. So when to refer to nephrology? KDIGO actually has guidelines for this. The guidelines sort of include acute kidney injury, GFR less than 30. I think GFR less than 30, is a pretty much an automatic referral to nephrology. Again, for persistent CKD, persistent proteinuria, rapid progression of CKD, resistant hypertension, persistent electrolyte acid-base abnormalities, and then concern for systemic autoimmune disease, pregnancy, and there's a concern for underlying CKD. And then I think, again, as a plug, you would still consider e-consult for some of the less concerning indications for referral. This chart here is just to show the duration of nephrology care before patients start dialysis. And you can see that, it's actually not as many patients as you think are receiving care from a nephrologist for more than a year. More than a year would include the patients in gray, more than a year would be in blue, but only about 35% of patients end up having nephrology care for more than a year prior to starting dialysis. And if you look at this map here, this shows how the prevalence of greater than 12 months of pre-ESRD nephrology care. And you can see that here in Rochester, Monroe County area, we actually tend to do pretty well. We're sort of in the middle towards the higher end. And so we're doing relatively better than some other parts of the country. But why do we care? There is some data to show that an optimal start to dialysis has increased survival for patients. And so an optimal start to dialysis means that they have some sort of definitive access to dialysis, not necessarily a tunnel dialysis catheter, but more importantly, an AV fistula or AV graft, or if they're going to be doing peritoneal dialysis, having a PD catheter in place And having it be a planned dialysis start as opposed to a, sort of crashing in through the ED and urgently starting dialysis through a temporary HD line. And then, and also having at least 6 months of follow-up by a nephrologist before starting dialysis. You can see here that the median survival for patients with an optimal start was 7.8 years, and the median survival for suboptimal start was only 4.98 years. And that obviously has an impact on healthcare utilization. When we look at patients who had an optimal start, and you can see the definitions there for an optimal start for dialysis. This was another study done, published in 2018, but optimal starts were associated with a 65% reduction in sepsis, 56% reduction in 12-month mortality, and it was also associated with lower healthcare utilization. You can see the number of inpatient days for an optimal start versus non-optimal start on an annual basis is significantly less for the patients with an optimal start, and so is the use of specialty care and vascular surgery. Nephrology care, of course, there wasn't any difference, as one would surmise. And so to finish up, I included the GFR calculator. I tend to reference it in the e-consults that I do if I am ever suggesting to use a cystatin C. It's fairly easy to find on Google. The NKF provides a GFR calculator, and you can plug in all the information, serum creatinine, serum cystatin C, and then it will give you what the estimated GFR is, both with and without including the cystatin C level. But then if you scroll down below that, it actually does help you categorize the CKD based on the level of albuminuria, and then it will also tell you what the potential risk of progression is and whether or not to consider referral to nephrology, and what the frequency of lab monitoring should be. And that's one way to sort of help think about risk of progression. But another helpful tool is using the kidney failure risk calculator, which is available at kidneyfailurerisk.com. And so if we plug in information, for example, for a 65-year-old male with a GFR of 47 and a urine albumin to creatinine ratio of 45, it will then ask us if we want to include additional information like albumin, phosphorus, and bicarbonate. You don't have to include that information, but if you choose to, it can provide an additional, maybe a more accurate estimation. But it will then tell you their stage of kidney disease, but more importantly, tell you an actual percentage in terms of the risk of progression of kidney disease. And I think that can be helpful, especially for patients as well, when they're wondering how concerned should they be. So for example, this patient using this criteria I mentioned has a 0.87% risk of progression to kidney failure requiring dialysis or transplant in 2 years, and a 2.8% at the 5-year mark. And then it can also help patients maybe understand if they take an ACE inhibitor or achieve good glucose control or blood pressure control, how much does that risk drop by? And so you can see here, this patient really didn't have a terribly high risk, but for patients who might be at higher risk for progressive kidney disease, the percentage differences might be more outstanding. And so with that, I will conclude and leave it up to any questions, and thank you for your attention.
Dr. Gorwal, thank you so much for that. That was fantastic. I'm hoping that you can share your slides with us through an email if possible, so we can share it to the group, because I think that would be very helpful for all. I'm going to hold off on questions right now and move on to Dr. Taylor to see, and we can take group questions at the end. Dr. Taylor?
Hey, thank you. I'll try to share my slides here. I'm Matt Taylor. I'm one of the other nephrologists here. Does this look like it's working?
Good to go.
Good to go. I'm going to talk a little bit about kidney stones, how to prevent them, and how to work them up. I know it's a little bit late, and this is a shortened version of an already fairly long talk, so I'll try to move through this fairly expeditiously. And we'll go there. So kidney stones have been around with us for a long time. This is a person from late antiquity, I believe. We've always struggled with them as a species. They've always been something that we've thought and wrote about. And we've long since had significant mortality and morbidity from them. This is one of the first guys who wrote about amyloidosis. He's kind of a personal hero. I'll go through some basics facts about kidney stones, their epidemiology and what types of kidney stones we frequently see, how to work them up, and then kind of a little bit more on the practical side of things, how to prevent them for general stone advice, and how to prevent specifically calcium stone formation and when to send them to stone clinic. I'm not going to harp too much on the significance of this. Kidney stones are pretty common. They cause a lot of morbidity and mortality. They're pretty painful. They cause infections, kidney injuries. Nobody really likes them. They're pretty common in the US. They're supposedly more common in the Southeast, in the quote unquote stone belt, mostly among in the middle age, not the Middle Ages, but in our middle age, and a little bit younger in women. We'll see a little bit about why that is. If someone has an acute kidney stone, probably all know how to manage these pretty well. We're trying to figure out, can this person expel the stone on their own? Will they do so within a month or so? Or do they need a little bit of help from urology? If the stone's small, under 5 millimeters, you can try to have them expelled on their own. We give it about a month. You hydrate them, try to keep their pain under control, and you can give them some tamsulosin to help them expel it. But if it is obstructing, if you think it's causing infection, or if you think it might be related to a kidney injury, you may want to have it dealt with a lot sooner, and that would be a time to get urology to see them pretty rapidly. The urology phone number is actually just 5 ESWL, extracorporeal shockwave lithotripsy, and you can get them in usually within 48 hours if you really need to have somebody see urology. For bigger stones, they really need to see urology. If you do have had someone have a kidney stone, they're now safe, don't have an obstruction, not infected. What they probably want to do is never go through that again. So this is kind of a lot more what my job is just to help try to prevent kidney stone formation and try to figure out why they made it and if there was anything that you can do with that. So this is kind of the main things that I look into to talk with them about. Are there risk factors that you can identify? Are there medications that they might be having? You may notice some of these slides have a picture of Dean Cundy. He's one of my favorite photographers. You get a copy of these slides. These are the ones that I tried to make that are kind of higher yield information that may be worth referencing at some point in the future. So these are the things that we would look for. That they may be having, other medical conditions, and some medications that would cause a lot of kidney stones. We'll go through some of those in a little bit more detail in future slides. Types of kidney stones that people see. So most of them are calcium stones, and of those, most of those are calcium oxalate stones. These are run-of-the-mill kidney stones. We'll talk about prevention of them the most. Calcium phosphate stones is the other type of calcium stones, with a slight twist on them in that they are, well, pH dependent. We'll talk a little bit about that. There's a few non-calcium stones that we occasionally see, mostly made out of uric acid or struvite. People who are making non-calcium stones generally should be referred to nephrology. So these would be folks that we would love to see and maybe able to help with a little bit. There's some really rare kidney stone types that you might see, but they're pretty unusual. The rarest kidney stone is William Shatner's kidney stone because he only had one of them and he sold it for $25,000 for charity. Kidney stones by age, as you can see, most people form calcium oxalate stones. Apatite, that is to say, the most common form of calcium phosphate stones are a little bit more common in younger folks, and particularly in females. Uric acid stones tend to be a little bit more common later in life. So if you're going to try to evaluate someone to prevent a kidney stone, here's what you're going to want to find. Some of the history about their kidney stones themselves, what risk factors, things from the previous slides, what do they eat, what do they drink, what are things that may be contributing to supersaturation, and you're going to want to look at labs. Ideally, you've gotten one of these stones in the past and you've ground it up and figure out what the heck the stone is actually made out of, whether it's calcium, whether it's uric acid, whatever. You can also get hints from that on your analysis from a crystal exam. And it's pretty helpful too to look for reasons that someone might be making kidney stones, particularly do they have sarcoidosis? Are they vitamin D toxic? Are they primary hyperparathyroid, but just never had overt hypercalcemia before? Those would be things that I look at. And so you've hopefully gotten a little bit of an idea of why maybe somebody is having kidney stones from that. What are the things that we can do to try to prevent them? So for all folks, we try to give general kidney stone advice. And this is the things that have been shown to try to prevent kidney stones for most people. And most of them are pretty straightforward. Volume's the most common one that we hear. The more you urinate, the more diluted everything is, the less everything is super saturated. Someone should be peeing about 2 to 3 liters per day to help maximize that. At some point, there seems to be a drop off, and people who are peeing a whole lot may not get any more benefit after about 3 liters. This is liters of urine that someone's making, not how much they're drinking. Some folks, it's really hard to get their urine volume up because they may have like an ostomy that is preventing them from being adequately hydrated all the time. In terms of one question that I get is, well, what liquid should I be drinking? My general rule of thumb is if you can drink it and you can pee it out later, it's probably better than nothing, with the big caveat of sugary things and colas are probably not the best because they are going to have other things that will increase calcium excretion that we'll talk about a little bit later on. We used to recommend not coffee or tea because they have a little bit of oxalate, but the emphasis here is a little bit of oxalate, and it's probably not worth fighting that fight. If someone is getting some volume in through coffee, that's at least some volume. Sodium, this is something we don't talk about a lot or don't think about a lot, but the more salt that somebody is eating, the more calcium they're going to have to excrete. These are studies, I think, done on medical students that demonstrate that in normal physiology. You eat a bunch of salt and you will have to excrete more calcium, which increases hypercalciuria. So decreasing dietary sodium is actually really helpful for all stone formation, particularly in calcium stone formation, because it decreases the hypercalciuria. Protein in the diet has a similar effect in that it increases calcium, but it also decreases urinary citrate and increases oxalate. Some of this comes from pretty complicated mechanisms, but the long and short of it is we probably should be recommending the people to be on a lower animal protein diet, and we can actually measure some of this, as we'll see in the 24-hour urine. But we should try to find out, is somebody on a very high protein diet? Maybe that's something that can be brought down. One that isn't on the 24-hour urines, but also contributes to calcium excretion, is how much sugar someone's getting, particularly simple artificial sugars like sucrose, fructose. These, for reasons I'm not entirely sure I understand, do increase calcium excretion. These studies were done on medical students who were just given a bunch of glucose to drink and then had to urinate for a little while afterwards, and did demonstrate exactly that. It increases calcium excretion. So decreasing sugary intake should help hypercalciuria as well. And how much calcium should somebody be drinking, particularly or eating it, particularly if they're getting, if they have calcium stones? This is something that the guidance has changed on over the last little while, but people still get pretty confused on. So if someone comes in with a calcium stone, should they be on a dietary calcium restriction? In the old days, we tended to, but there was a study from 2002, fairly famous study, that showed actually was questioning the idea of, well, if someone's eating calcium, that's probably binding some of the other things in their gut and is lowering their oxalate or their phosphate, and may not actually be worthwhile. So this was a randomized control trial that was done between a low calcium diet and a low protein, low salt diet with a fairly normal calcium intake. I do find it fun that they differentiated between Parmesan cheese and just other cheese in the study. And the study was done in Parma, so that I assume they know what they're talking about here. It did show that actually on a normal calcium diet, people had a lower incidence of kidney stones. I think it's also worth noting in this that the difference wasn't seen for a couple of years. And some of this is because of how long it takes to actually form a kidney stone, and kidney stones that are preformed along the renal calyces are going to be excreted at some point. And the mechanism for this is thought to be from oxalate binding predominantly. And there's further evidence and more that we worry about putting people on low calcium diets and putting them into a negative calcium balance. So the recommendation now is that someone should be on a normal calcium intake, probably shouldn't be supplementing with calcium, but this is the ins and outs of general stone advice. So simple stones, who do you refer to nephrology? Someone who's having a lot of them, someone who's had kind of an unusual type of calcium, an unusual type of stone, someone for whom you're worried that one therapy, particularly do I give calcium citrate in someone with phosphate stones, I think are worth referring. Young patients, severe episodes, and honestly, I think also there's some value in if there's a little bit of health literacy, misunderstanding, etc. We do have a decent amount of time that we can spend with patients that may free up some extra time that we can go over. Okay, well, what dietary things are we seeing? And I like to review the 24-hour urine with folks, which is the main thing that I'm gonna get. I don't know if these are things that y'all have ordered in your own practice for kidney stone. This is the 24-hour urine I'm talking about. It's a proprietary supersaturation profile that's done by a company called Litholink, where you get all of these. Here's an example of a result of one. You get all of someone's kidney stone risk factors, and it measures, or it calculates, I should say, the relative supersaturation rate of various minerals. So if I know that this person is making calcium oxalate stones, I can see that while their supersaturation of that is actually quite high, I can see individual risk factors for this person. High urine calcium, relatively high oxalate, and an elevated dietary sodium on the dietary factors as well. And we can track these over time to see, well, have we made a change? And what I go through with folks is their supersaturation rate. I'm not going to go through the details on this one, but you can see this is someone who's had numerous ones and has had ups and downs on their supersaturation and calcium oxalate attributable to various things. The calcium in this person has gone down due to the thiazide and then coming off, as we're going up later on. So if someone has one of these 24-hour done, what we'll mostly find is that people have one or more risk factors, and that's usually low volume, high calcium, high oxalate, low citrate, or high uric acid. And these would be the metabolic targets that we can help try to treat for folks. Hypercalciuria is one of the more common, and this is a urine calcium over 200 to 250 milligrams per day. It's usually just idiopathic hypercalciuria, but this is again where I like to go through and make sure, is there any reason that somebody's having hypercalciuria? Maybe they have a little RTA, maybe they have a little undetected hyperpara. This is my kind of list for that. These are folks that I would give general stone advice to, put them on a normal calcium diet like we had talked about. And then the big question on thiazides recently, because there was a big trial for this in March. I'm not going to harp too much through the ins and outs of this trial. Thiazides have been one of the staples of treating hypercalciuria and kidney stones. This is a fairly dramatic graphic from Fred Coe, looking at a case series of folks who are having frequent stones, and then upon starting thiazides having fewer events. The no stone trial, I think, is worth pointing out a few things. First of all, it was randomized to the dose of hydrochlorothiazide, not to actually how much hypercalciuria each individual patient had. I actually didn't have a whole lot of hypercalciuria. It was only about 60% of the patients in the study were people that we would put on a thiazide anyway. And the follow-up was pretty short. It was 2.9 years, which from other studies, there's frequently not much of a split until after a couple of years because of stones that are previously made. There was an interesting reduction in radiographic stone recurrence, meaning imaging folks showed there was less stone growth and fewer new stones if they were on a thiazide, which was dose dependent. So in short, the no stone trial does suggest that maybe thiazides are not useful in treating calcium kidney stones. I don't think this study actually is one that we should use to guide practice. So I think most of us still give patients thiazides if they're hypercalciuric. So my approach is kind of this: try to treat them with dietary changes. Can you just drop the supersaturation a little bit down? You find a reason for it. Do another 24-hour urine, thiazide, then do another 24-hour urine and see if you've actually made a difference for these folks. Hyperoxaluria. We see a lot of hyperoxaluria, and we've all talked about what are the various oxalate-containing foods. And the problem with this is that there's a very small list of foods that have a lot of oxalate, and then there's a very long list of foods that have a moderate amount of oxalate. So I focus on helping folks find the kind of higher yield list of foods to avoid. And then the other thing that I look for is there another reason they might be hyperoxaluric? Frequently, it's some kind of a malabsorptive problem. Folks who have had gastric bypasses, bowel resections, etc. And occasionally vitamin D supplementation as well. I've never seen primary hyperoxaluria, which is why it's a little smaller. Kind of a silly one. Low citrate in the urine, hypocitraturia. Citrate's a product of metabolism that binds calcium in the urine, so prevents kidney stone formation. So folks with low citrate are folks that we'll frequently just treat with citrate to replace it, with a couple of things to know about it. One, we know that it does decrease kidney stone formation. We give it as potassium citrate. This is a potassium load, and the goal is to both raise their urinary pH, which will increase endogenous citrate production, and to replace a little bit of citrate. So you could actually just use alkali therapy instead of citrate itself if need be. This is kind of the data supporting this use. The things to watch out for: you're giving people potassium with potassium citrate. If you give them sodium citrate, you're giving them a lot of sodium, which may be a little bit counterproductive. A lot of people have side effects with this, which is usually what limits the dose. And it will alkalinize their urine, and frequently that's the point. So folks who make calcium phosphate stones, that may be counterproductive. So you tend to be a little bit more leery of it in calcium phosphate stones. Folks, this is a little bit of a questionable area, but folks who have hyperuricemia will form calcium oxalate stones a little bit more frequently than others. It's not entirely clear why. And the folks who have this, generally it's because of abnormalities in purine metabolism, though you can frequently find high animal protein diets. You can help decrease this a little bit. Unfortunately, frequently, even by decreasing somebody's dietary consumption of protein, it may not be enough to actually lower their urinary uric acid. And the actual utility of treating uric acid with allopurinol is a little bit questionable. So I tend not to do it unless somebody also has hyperuricemia or history of gout or something to that effect. approach to that. Calcium phosphate, I kind of mentioned most of this beforehand. Calcium phosphate would be the second most common type of kidney stones, and they're another calcium stone. The thing about them is that they are pH dependent and they'll precipitate an alkaline urine. So treatment of hypocitraturia with potassium citrate may raise the pH and actually increase the solubility of calcium phosphate and may be counterproductive. So we'd be a little bit more hesitant to do that. It's also, when I see folks with calcium phosphate, I do wonder if they've got another reason for it. So I'll look at to see, does this person maybe have evidence of an RTA or hyperparathyroid, or are they on a medicine that might be doing it, like carbamazepine or acetazolamide or something to that effect. We're a little over on time. Uric acid stones, generally folks refer to us. These are ones that can actually be treated simply by alkalinizing the urine, and we can actually make the stones regress, which is actually pretty cool. Folks who have this don't always have gout, but if I see somebody who has uric acid stones, I always try to figure out if they're at high risk for gout. So those would be other folks that I'd look for hyperuricemia on. And then struvite stones, these are bad news, and these would be ones that need to get into urology pretty quick and need to come out, as you're probably all aware. These are infection-related stones, and they'll just keep coming back until the whole stone is removed and they're completely treated.